Hello, I'm Manoj Karmakar. In this next video, Professor Philip Peng from the Faculty of Medicine at the University of Toronto is going to discuss with us ultrasound-guided nerve blocks for chronic pelvic pain. If you like any of our videos, do remember to like and share it with your friends. Also remember to subscribe so that you can get regular notifications of any future uploads. So now enjoy the upcoming video.
Well, thank you very much, Manoj. Yes, always good to connect back to ISPSS, and thank you for the invitation. The area that I'm going to cover is on the other end of the body, is in the pelvic area. This is my disclosure slides, and a lot of those pictures are coming from these three books as well. What is the scope of the area that I'm going to cover? So chronic pelvic pain, according to the one of the big society, they say this is the area that is not related to cancer, involved in related to the pelvis in both male and female, continuous, recurrent, at least for 6 months, associated with a lot of quality of life issue like negative cognitive, behavioral, sexual, and emotional consequence. The gynecologist, American College of Obstetric Gynecology, just have a very simplified version in terms of anatomical, is actually in the lower part of the lower quadrants on the left and right side, the gluteal area, and also perineal area. So if you have the pain that you feel that in that area, that is the pelvic pain. There's a lot of procedures I would like to cover, but I just highlight mainly the technical aspect into three areas: the border nerve, pudendal, and deep gluteal syndromes. So let's talk about the first one: either inguinal, either hypogastric, and genitofemoral. What are the nerves here? So they are the nerve coming from this diagram. You can see well here. Let me just zoom it out. The either hypogastric and either inguinal, they are emerging from the lateral border of the quadratus lumborum, and you can see it. High one is the iliohypogastric, either inguinal, but the genitofemoral just at the anterior surface of the psoas. You know, see the genital and femoral branch here. What are they supply? The iliohypogastric, yes, supply the groin area and a little bit on the lateral part of the hip. So this is an area that is important. A lot of people forget about this. So when a patient have some upper hip pain, it may be actually a kind of a presentation of iliohypogastric. What about inguinal nerve? Is mainly on the middle aspect, very middle aspect of the groin, of the thigh. And there's some overlap in terms of the coverage between either hypogastric and either inguinal. What about genitofemoral nerve? So the genitofemoral nerve have two branches. The femoral branch usually is go very subcutaneous, very superficial, and this is important. That actually emerge between the lateral circumflex femoral artery and the femoral artery. So this is actually one of the landmarks you can find the femoral branch. The genital branch have an intimate relationship with the spermatic cord and inguinal canal. The genital branch all go through the inguinal canal. But for male, there is a spermatic cord. It can be inside or outside, and there's a lot of anatomical variation. And what does it supply? The femoral branch supply a big part of this area in upper thigh, and the genital branch supply the genital area, whether it's a scrotum or vulvar area. So knowing this, the distribution is important. Now, this is a very important pictures. These three nerves, they seem that they like each other, and there's a lot of overlap in terms of anatomical distribution. And sometimes in some patients, the genitofemoral nerve supply much bigger area than the inguinal iliohypogastric, and vice versa. So, and just actually be cognizant about this. So for some individuals, same distribution, genitofemoral nerve block will do all the job, and sometimes you need to do all the three nerve. And that's the reason why we call the border nerve, because they patrol along the border between the body trunk and the thigh. Who are the patient at risk? Post-surgical is one of them, like what surgery? The appendix, if you have an open surgery, which rarely now, inguinal hernia surgery, and most commonly the lower abdominal incision surgery or cesarean section. This is the type of a surgery that I see most related to the border nerve syndrome. And this is the area that they usually have pain along the groin, upper thigh, and the genital area. Now, a lot of time we think that the patient usually have a history of surgery. I'll find probably is around 1/3 of the population. They have an intimate relationship with from the history that related to the surgery, but then it can present early and late. Why late? How late is it late? Late can be like 1 or 2 years later. So what's the case? So yes, if it's actually soon after the surgery, the patient have pain, easy to get the temporal relationship. But sometimes it just happened like 1 year later. And the reason is this free nerve, the border nerve, they tend to glide happily between the different plane before it go to cutaneous. So there's a lot of mobility. If you actually do a dynamic scan, it glides. But then when you have a surgery and you limit the mobility, and sooner or later when you have to move, keep moving. And then when you move, the nerve keep gliding along a very strict and fibrotic plane. And then sooner or later, it will be screaming and not happy and have a late presentation. And I find that quite common, more than half of them, they may not have any etiology at all. Diagnosis is clinical. I think that the cardiac sign is important. Just make sure that it's in the abdominal wall and it's quite discrete, unlike the visceral pain, which is quite ill-defined. Now, I think it is actually at this step, just want to mention the importance. We see two types of those border nerve syndrome. One is actually purely a nerve related. For whatever reason, they usually exhibit a neuropathic pain character. You can use DN4, but typically they have a sensory changes, whether it's negative numbness or positive hyperalgesia. So that's actually related to the nerve. But quite common, we see those have no neuropathic pain pictures, but it's actually still in the abdominal wall. And I still will treat accordingly, but the management and prognosis are very different. So let me just go back to this later on. So it can be in the abdominal wall related to the nerve, or which is neuropathic, or not related to the nerve, which is somatic. The intervention, well, for either inguinal, either hypogastric, is fairly easy to see. If you're using ASIS as a landmark, just one or two or three finger breath posterior to this, you can see beautifully. This is medial, is a lateral. They are here between the internal oblique and transverse abdominis. They are very close to the iliac crest, within one, at most 1.5 centimeter. If you see something further away from this, you are seeing subcostal nerve. So they are very close together. You cannot even differentiate closely. Even you can see this as a two nerve. When you inject, they behave the same because you can inject both. You cannot have a discriminative nerve block. And usually there's an artery here. I don't know, you can see from the scan, is a deep circumflex artery there. So this is actually a scan of me showing that, yes, I have beautiful anatomy. You can see all the free structures, deep circumflex, either hypogastric, either inguinal. All right, so when you do ultrasound, yes, you can fairly confident you can block the nerve. And that's actually a very reliable procedures. What can you do? You can do repeated, I usually do a series of free local anesthetic steroid injection. And this is fairly typical for those who have nerve-related symptoms. They will respond to a certain way. And we have actually done a retrospective review on those 60 patients in probably we capture over 2 years because we've seen quite a lot. We find that for those refractory neuropathic pain, now I'll talk about refractory pain. Around half of them, they respond to those series free injections more than probably 3 to 6 months. Now, but for those who are related to the somatic component, they respond just mainly to the local and not much to the steroid, but they feel good, but have the honeymoon effect. Honeymoons that basically you feel good for just 1 day. That's a honeymoon effect. So in that case, you want to prolong the effect, you can either use a pulse, RF, or sometimes I will bite the bullet and do the ablation. I have to say that my experience with pulse is not really different from the local anesthetic injection. And quite often time I counsel the patient, I would do the true ablation. There's a new technique in the last 10 years, the surgeon doing triple neurectomy. They do a laparoscopic approach, as you remember the ultrasound, the anatomical picture I showed you right from the start, the free nerve can be approached in the posterior abdominal wall through the laparoscopic approach. And I used to say, well, it's a bad thing to cut the nerve, but it depends on the circumstances. They actually pull the nerve from the abdominal wall and chop it right at the muscle, and so that the nerve retract back and bury inside the muscle. And our surgeon and general surgeon, 3 of them, and also a gynecologist are quite interesting and have been offering this. They went south and learned this technique. All right, the genitofemoral nerve. They are actually the key landmark is the inguinal canal. So in men, it's quite easy. You can just scan around lateral and superior to the suprapubic tubercle and see a very beautiful structure with multiple lumens. There is 3 arteries, 1 vein, and 1 supramedullary cord there. And 1 vas deferens. Very, very beautiful structure. And how can you see this? I usually, for men, it's easy. You just find the suprapubic tubercle is right there, and the cephalad, and there's a video. And then I scan more lateral, and then gradually you can see a very beautiful multi-lumen structure here, and just roll towards the lateral side, multi-lumen. And here, if you are not able to see, well, just ask the patient to cough. Focus here, cough, boom, you see the venous dilatation. Cough again, boom, you can see this. So it's a very, very beautiful structure. Now, for those who just forget your anatomy, just to let you know that for female, you don't have spermatic cord. So you can use this technique. The other technique you can use is just find the femoral artery, just like you usually do, and look at the sagittal plane of the femoral artery. And then you trace it. So there's a femoral artery, you trace the sagittal plane, left-hand side is the head, and you can see the artery dive in, that it becomes it originates as an external iliac artery. And this is a pubic rami here. So here, left-hand side is the abdominal cavity, right-hand side is a leg, and you see this as the inguinal canal. So this is a picture. So let me just pause it here. So it's important, when you see something like this, a circular, whether it's a man or woman, a structure without spermatic cord, don't get excited. The first thing you ask is, are you able to see the scapa fascia? The scapa fascia defines the entry to the spermatic cord, the entry to the inguinal canal. So there's a multiple line here. So, but this one that's continuous across the plane, and it's a white, black, white. And so that is a white, black, white. And when the needle go through this, you are then entering. So I'm just deep to this. Now I'm entering into the inguinal canal. So in a moment, you see I'm inside the inguinal canal, but outside spermatic cord. So I inject half of that, like 4 cc outside. And then the next one, I inject here. Then I inject another 4 cc inside. The reason why I inject outside and inside, because the genital branch of the genitofemoral artery, femoral nerve, they can exit outside spermatic cord easily in the inguinal canal. And so I don't want to miss it. So just make sure that you don't put any epinephrine containing product in those injected, because it will cause spasm and ischemia of the testicle, which is a very bad complication. The procedure, you can do local anesthetic, radiofrequency, and triple neurectomy. Someone will say, hang on a second. You just flood the whole inguinal canal. How can you say you can see the nerve during radiofrequency? Yes. There's a technique that actually Dr. Morigo from Austria told me that if you find the femoral artery, if you trace the external iliac artery and find the branch where it branch out the inferior epigastric artery, which is in the rectus sheath, you can actually see the junction, and you can see the genital branch, which is here. So this inguinal canal, you can see the genital branch of genitofemoral nerve enter in the canal. Just before it enter, it cross in this junction here. So what does it mean? Well, trace the rectus sheath. You can see the rectus abdominal muscle, medial lateral, inferior epigastric artery. See this. So this is where the ultrasound is. So you see the inferior epigastric artery and trace it down. And now you see this inferior epigastric. And also at the same time, you see the external iliac artery. And then later on, trace it down further when it merged together. these two arteries merge together. You see the general branch just coming there, and then you can do the block or you can do the radio frequency. All right, so in terms of anatomy, I already explained to you the inguinal idiohypogastric nerve, and also some the sonor anatomy and different way to find those. We talk about the patient selection and different type of management. So we go further and go to pudendal nerve. So much to talk about. I focus mainly on the technical aspect. So there's a term called pudendal neuralgia, is a pain arising from the territory of a pudendal nerve. But the one that we select, that's important, the one we select for the procedure is mainly the pudendal entrapment neuropathy. Now, what is the difference between the two terms? So when someone have a valvular injury, valvular trauma, you can have a pain in that area, but doesn't mean that you have a nerve entrapped. The nerve is entrapped, then that are the candidate that probably is the best candidate for the injection. Where are the sites of the entrapment? One is between the sacroiliac ligament, and the green is sacrospinous ligament. I make a cutout so you can see it's entrapped between the two ligaments. I have a video here, so you can against the sacrospinous ligament, pudendal artery and the nerve, and then I have the sacrotubus ligament and make a cutout. So there's one area you can entrap, and so that is one side of the injection. And then the nerve keep going to the anterior and across the ischiotuberosity to here, where the obturated internus muscle have a fibrous tunnel called the Alcock canal, and where is a second site where the nerve can be entrapped here. So you can either inject between the sacrospinous and sacrotubus ligament, or you can inject in the Alcock canal. And how do we get into this you call interligamentous point? Always start from high above, find the PSIS, see the whole iliac crest, medial, sacrum, lateral, and then slide down. In the glycosartic fossa, you see two muscles, the gluteus maximus, piriformis, is the sciatic nerve. The bone structure, the signature here, the ischium is round. But when you come down to the ischial spine, the signature of the spine will be long and straight, and you will not see the piriformis. And at that time, you will see the sacrospinous ligament, and then sacrotubus ligament, and then you can see the pudendal artery. This is how it looks like. So this is long and straight. You don't see any piriformis muscle anymore. You connect on the middle side, sacrospinous ligament, and there is a neurovascular bundle there. So you can see one or two, depends on the cut of the pudendal artery. The nerve 95% is on the middle side. And that's the reason why I always on the middle, I put the needle on the middle side of the artery for two reasons, because the nerve 95% is on the middle side. And the second reason is on the lateral side of the artery, if you inject, there's a chance that you spill further to the sciatic nerve, which I don't want to. So this video is medial, this gluteus maximus. When you scan more distal, the bone get longer and stricter. And on the middle side, boom, you can see the sacrospinous ligament. You tilt, you don't see it. You tilt it back, you can see sacrospinous ligament. And then here you see the neurovascular bundle. You put the needle medial to this. And this is the injection. Oops, I don't know why the video is not working. So you can put the needle between the two ligaments and just medial to the artery. Alcock canal. So now just how do you find the Alcock canal? Remember, the last video just showed you in the interspinous ligament at this level. When you scan from the glycosartic fossa, ischial spine, when you scan more caudally, you will be in the lesser sciatic fossa. So when you're in the lesser sciatic fossa, the bony signature, instead of long and straight, it will become completely like this, curve. Now it's so curved, so small that you have to interpret this in, we learn this from the fusion. So actually, let me just walk through here. The bone, instead of long and straight, become curved. And here it dives like a cliff. So this like this, the bone is here. But what about this area? It's still black. And that is the obturated internus muscle. And a lot of time when you go from the interspinous ligament plane and you look at the artery, you trace it down, you can see the same pudendal artery is here. So this is actually where the Alcott canal is. There's a lot of structure you can see, but it's a little bit out of the scope here. Sacral tuberous ligament, you see the levator ani muscle, coccygeus muscle, but here is the bone, obturator internus, and here early part is the Alcott canal. So so I think it's important that the target for those who respond well to the injection are the one, not just pudendal neuralgia, but exhibit the pudendal entrapment neuropathy. There's certain diagnostic criteria, which is a little bit difficult to cover everything within this short period of time. There's two sites, is the interspinous ligament plane and Alcott canal. And a lot of time I just mainly inject into the spinous ligament for the diagnostic and therapeutic reason. I usually do a series of 3 injections. I can do pulse. I try not to burn the nerve because you need those muscle for a little bit of continence. A little bit scary if I try to burn the nerve. Surgical decompression, I used to send the patient to Europe or US. Now I have a gynecologist who have a lot of interest in doing this laparoscopically to decompress the nerve. Now, one last note I haven't mentioned. So a lot of time that the pudendal neuralgia, we always think this classical symptom pudendal entrapment neuropathy. Neuropathic pictures, we spend everything there and there's no decompression there. So be aware that there's a possibility that the pudendal nerve, which is from S234, can be compressed and trapped within the piriformis muscle. So we say actually, well, how does it happen? Yes, the S2 and S3 in around 20 to 40%, they form within the piriformis muscle and can be entrapped. How do you diagnose? Well, clinically, but also with we call a special MRI. It's called MR neurography. And when you can have a specialist who can do this, you can see the sacral S2, S3, whether it's entrapped, and see whether there's any T2 signal, whether there's an edema in the area as well. And you can do a diagnostic block with X-ray and see whether it actually relieves them. And then you can do the entrapment with a laparoscopic technique. All right, so quickly go to the deep gluteal syndrome for the introstal plane. So deep gluteal syndrome is pain in the gluteal region. And this is very similar to in the past when we talk about the piriformis, but there's much more profound. So I just want to focus on this picture. This is the medial. The medial is a lateral. The area can involve a lot of muscles from the piriformis, obturator internus, and the quadratus femoris. Can be involved in the greater trochanter and even sacrum, and there's a multiple nerve involved. So it encompasses a large area. So what does it mean to you? Well, first of all, there's a lot of muscle involved. So when you involve the quadratus femoris, this actually is called the femoral ischial syndrome. So there's another syndrome. You have obturator syndrome, you have a piriformis syndrome. And most important is the nerves are not as simple as you think. Remember the variation of sciatic nerve within the piriformis? That is actually way oversimplified. A lot of time the nerves are involved in a very different way. One example, the nerve can be just stretched. When you stretch a nerve, 6% you can get a neopraxia. When you stretch a nerve, 12% you can get a complete block. So how can you? So normally when you actually maximally flex the hip and knee, you get around 3 to 4% of the stretch. You don't get numbness. But sometimes when you have some adhesion that affect the mobility of the nerve, you can result in sciatic nerve stretching. And that happened in some patients who have some fiber span in the sciatic nerve. But the other thing is actually the mobility of the nerve and its effect is important because actually every time when you walk, the nerves are bouncing back and forth medial and laterally. I remember I was in Hong Kong and they treat me with one of the very difficult patients who is a sportsman who have this a tear in the hamstring and eventually form a calcification. And that calcification, that calcium form like a knife. And the nerve bounce back and forth medial and lateral. So the sportsman actually, when he runs, he's have those shocking feeling down the sciatic nerve. But when he's at rest, nothing. So we do a dynamic scan and find there's a calcium there. But the nerve, when we actually have a dynamic scan, keep going towards the knife. And you can see why the patient have those pain. And the simple things is we decalcify with a fenestration technique, and the patient get much better. I just want to show you the fiber span, and there's a different type of fiber span. And they actually can be diagnosed mainly with MRI, this sciatic nerve, and this fiber span here. And then they require surgical operation. So this actually the fiber span here. After they remove, you can see the revascularization. All right, so just quickly to the deep injection. So there's very muscle to inject, but I think that the technique is very similar to what I just showed you for the pudendal. I go according to the iliac crest first, and then go to the gluteosciatic fossa. In gluteosciatic fossa, medial lateral, you see two muscles, gluteus and piriformis. And when you scan there, one of the most important thing is you need to see the superficial and deep border. So you need to see the superficial and deep border, because the deep border is where the sciatic nerve is. You can see the inferior gluteal artery, the descending branch there. The superficial, because you need to make sure that your needle pass the gluteus maximus. So if you don't see the superficial extent, don't see the distal extent, this is a poor scan. And the other thing that I just suggest you is I always toe in like this and have a needle from medial to lateral, or just 2 centimeters away from the probe. Otherwise, the needle will be very steep. You won't be able to see the needle. And the obturator internus is very similar in terms of the aqua canal. Remember, you want to see the obturator internus in the lesser sciatic notch. So its medial is lateral, iliac crest. Now gluteosciatic notch here, gluteus maximus, piriformis. Now ischial spine, long and straight. And then you scan further distal, the bone from long and straight become short and curvy. And here the bone down, and look at this. What is this black mark? This is obturator internus. So the bone come down like this, the obturator internus come down like this. And this is actually the obturator internus. You can put the needle here, and you hit the bone and pull back a little bit, and you can see the injection. All right. So I want you, if you haven't heard about this, I want you to open the term. Deep gluteal syndrome is much broader idea. Just like we don't call the trochanteric bursitis anymore, we call it GTPS, Greater Trochanteric Pain Syndrome. There's a lot of muscle. The muscle can be related to these 3 muscles here, the nerve, and can be related to different pathology, not just the variation of the piriformis muscle, and the treatment contingent on the cause. So I condensed a lot of information in this single talk. I'm sorry for this. Thank you very much.